in first professional MBBS, usually questions from this topic usually will not be asked, but if you are growing well, questions from re-entry arrhythmia will be asked. So, I told you there will be 3 different segments in abnormal ECG which will be asked, right. One is acute coronary syndrome or myocardial infarction or ischemic heart disease. Second is heart block, and third is arrhythmia, that means rhythm disturbance. So, today I will talk about rhythm disturbance. Okay. So, rhythm disturbance, it is also called arrhythmia. Okay. Rhythm disturbance is also called arrhythmia, and particularly we will focus on okay, let us focus on what is re-entry. So, amra re-entry ki jinishta let us understand, right. Okay. So, from the name suggests re-entry. Okay. So, it is again entering, right. Okay. So, you see this is normal myocardium, right. This is normal myocardium and this is abnormal myocardium, right. So, these are dead cells, these blackish colored cells are dead cells and these are normal cells, right. And in this picture A, here all the cells are normal, right, all the cells are normal. Now, you know, through the myocardium, small electrical impulses pass, right. We call it action potential, right. From one myocardium to another myocardium, the passage of small electrical impulse is called action potential, right. And you know, myocardium or cardiac muscle cells are specialized cells which has got a specific structure called gap junctions. Okay. So, gap junction is made up of protein, 3 protein contributed by one cell and another 3 protein contributed by another cell, and it constitutes a tunnel, right. And the protein is called connexin protein, right. Okay, this is called gap junction, and gap junction can pass voltage from one cell to the adjacent cell. So, if you depolarize one myocardial cell, it will depolarize all the myocardial cells adjacent to it, right. Okay. So, here, this is normal myocardium, and you know, action potential can pass in this direction and in this direction as well. Okay. So, it is bidirectional, but what happens due to some insult or due to some ischemic event, right, due to some ischemic event, few myocardial cells are damaged or dead, right. Few myocardial cells are damaged or dead. So, what will happen in this case? So, here is the dead cells, right. Okay. Now, the flow of action potential will be unidirectional. Okay. The flow of action potential will be unidirectional. Why? Because the action potential which is happening over here, it can impulse, it can you know, transmit sufficient current from normal area to the dead area, right. But in this segment only these few cells are working, so they will not be able to transmit action potential sufficiently from the diseased condition towards the normal condition, right, from the diseased part to the normal part. Clear? এখানে এতগুলো cell dead আছে, right. So, only these few cells, this 9 to 10 cells, they will be transmitting voltage over here, they will be transmitting electricity over here, right. So, it is a case of unidirectional block, but এখানে যেখানে normal cell গুলো আছে, normal cell গুলো অনেক আছে, say for example 25. Okay. So, all these 25 normal cells can transmit action potential here, but these few cells will not be able to depolarize all these normal cells. So, here is unidirectional block, right. If you face a question or short note like re-entry phenomenon, you need to explain this. Okay. So, for re-entry to happen, one must have condition is unidirectional block in action potential conduction, right. And what is the pathophysiological basis of unidirectional block is this. Clear? Everyone clear with the unidirectional block, right. So, normal myocardium can pass action potential both ways, but a diseased myocardium can transmit action potential only in a single direction, not both ways. Clear? And if all the cells are dead over here, what will happen? there will be no flow of action potential at all, right? Okay. Now, a re-entry circuit to happen, there must be a circular path of myocardium. Okay. So, it is a circular path. It is a circular path of myocardium. So, here is another one myocardium and here is another myocardium, right? So, action potential can travel, this is towards the atria, this is towards the atria and this is towards the ventricle. So, action potential is coming from atria to ventricle, okay. So, it may follow this direction or it may follow this direction, okay. Or the action potential may circulate, I say. So, this is called re-entry, okay. So, for the re-entry phenomenon to happen, there are few prerequisites, okay. One prerequisite is this circular pathway, okay. One prerequisite is circular pathway, and another major important prerequisite is unidirectional block, okay. So now what will happen if there is a re-entry circuit in heart? It may give rise to different diseases, right. So, we will talk about all these re-entry circuits and what will be their effects, what will be the diseases and what will be the symptoms in a patient of re-entry, right. So, it is re-entry basically comes under arrhythmia or rhythm disturbance. Whenever there is a re-entry circuit in heart, right, and there is actually action potential flow through this re-entry circuit, very often it will happen that there is re-entry circuit, but it is not taking part any flow of action potential through this re-entry circuit. So, the patient will not be having any symptoms, but whenever the re-entry circuit is active and action potential is flowing, right, action potential is flowing or the electricity is passing, simply electricity is passing through this re-entry circuit, the patient will be having some symptoms, okay. The symptoms like palpitation, symptoms like dizziness, these are the usual symptoms in a patients of re-entry or arrhythmia, okay. Okay. So, re-entry will give rise to tachycardia, this is for sure. Whenever there is a re-entry circuit in heart, in and around the heart, right. So, it will give rise to tachycardia, that means heart rate will definitely be more than 100, okay, heart rate will be definitely more than 100. So, we divide re-entry tachycardia into few heads. One is AV nodal reentrant tachycardia and AV nodal reentrant tachycardia, and another is atrioventricular reentrant tachycardia, right. So, one is AV NRT and another is AVRT. AV NRT is atrioventricular AV nodal reentrant tachycardia, right, AV node. So, that means the re-entry circuit is located around the AV node, re-entry circuit is located around the AV node, and atrioventricular reentrant tachycardia or AVRT, that means re-entry circuit is big enough and it is covering the whole atria and ventricle, right. I am explaining one by one, okay. So, let us focus on AV nodal reentrant tachycardia, AV nodal reentrant tachycardia or AV NRT. Okay, this concept is clear to everyone, why there is unidirectional block, okay. If this is not clear, I will not be able to proceed, right. Okay. So, for re-entry circuit, there are two prerequisites. This is your question, very frequently asked in the Viva examination. What are the prerequisites for re-entry circuit? One is circular pathway, presence of circular pathway, and another is, say, another is unidirectional block. Very nice. Okay, so these two are the prerequisites for re-entry to happen, right? And re-entry will give, whenever there is re-entry in heart, there will be tachycardia, right? Heart rate will be more than 100, correct? Okay. Now, we will explain AV-NRT and AV-RT one by one. First is AV nodal re-entrant tachycardia. That means the re-entry circuit is there around the AV node. Okay. So, this is your heart. Okay. So, here is the AV node, correct? Here is the AV node. Okay. And there is a re-entry circuit. There is a re-entry circuit around the AV node. There is a re-entry circuit around the AV node. So, there is a re-entry circuit around the AV node. Clear? So, this is why it is called AV nodal re-entrant tachycardia. AV nodal re-entrant tachycardia. The re-entry circuit is located around the AV node. Clear? So, let us see what will happen. Now, there are two pathways in the circular pathway, right? There are two pathways. We do not know whether the action potential will come from above, below, or action potential will travel from below upwards. We do not know yet, right? So, there are two pathways. One is slow pathway, which is having a short refractory period, and another is fast pathway, which is having a long refractory period, right? One is slow pathway, another is fast pathway. So, you remember in this way, slow is short refractory period, SS. Slow is short refractory period, correct? There are two pathways. One is having one is called slow pathway, or it is having short refractory period, and another is fast pathway, which has got long refractory period. Slow pathway will have short refractory period, S for S, right? So, it has got short refractory period, and here it is long refractory period. So, what will happen? When action potential is coming from above, that means from atria towards the ventricle, it must cross the AV node, right? Action potential is coming from atria, it must cross AV node, otherwise it will not be able to enter into the ventricle. This concept is clear to everyone? There is only pathway from atria to ventricle. It has to cross the AV node, because the AV node is the checkpoint. You must cross it, otherwise you will not be able to enter into the ventricle, which is a very delicate structure, right? Okay. So, here is AV node. Okay, here is AV. Around the AV node, you have two pathways. Now, action potential has to come from the atria to this point, which is the upper part of bundle of His. Here is the upper part of bundle of His, right? It is the upper part of bundle of His. So, action potential must cross AV node atria, it must cross AV node and reach to the upper part of bundle of His. Clear? Now, it has got two options from above downwards. It has got two options how the action potential will travel and come to the bundle of His, upper part of bundle of His. Here is bundle of His, okay? Here is bundle of His, here is AV node, and here is the location of action potential right now. Now, this action potential has got two options. It can take the slow pathway or it can take the fast pathway, right? It can take the fast pathway or it can take the slow pathway. Okay, now what will happen? As because the refractory period are not same for the slow pathway and the fast pathway. The slow pathway is having short refractory period, right? Slow pathway is having short refractory period and fast path is having long refractory period. So, action potential will first travel through the slow pathway, which is having short refractory period, because it is open, it is accepting impulse. and this pathway which is having long refractory period, it is not accepting any impulse because it is in the refractory period. It has got a long refractory period, correct? So this pathway is not accepting action potential right now. Okay, this pathway is not accepting any action potential right now, but this pathway is accepting, right? As because refractory period is slow. During the refractory period, the conduction pathway will not accept any impulse. Okay, the short refractory period pathway or slow pathway, it has got short refractory period, so there are lots of gap in between. So within this gap, this slow pathway will immediately accept the action potential which is coming from above, right? So now action potential, it will travel through the short pathway because it is refractory, it will not accept any impulse, right? This is accepting. So action potential will travel in this direction and it will reach to the upper part of bundle of His. It will reach to the upper part of bundle of His. Now what will happen? Once action potential reaches the upper part of bundle of His, now the refractory period of the long pathway, refractory period of the, first pathway which is having long refractory period will be over. Okay. তাহলে অ্যাকশন পটেনশিয়ালটা যখন নামছিল, this pathway is not accepting any action potential, but this pathway was accepting. So action potential এখান দিয়ে চলে এলো, upper part of the bundle of His এ পৌঁছে গেল. Now once it reaches the upper part of the bundle of His, the refractoriness of the long pathway is gone. Now it is accepting action potential. So instead of coming down further, it will re-enter in the first pathway and go back to atria. Getting my point? So when action potential was coming from atria to ventricle, it finds two pathway at the top part of AV node, right? It finds two pathway. One is having short refractory period and another is having long refractory period. But as the long refractory period pathway, it is not accepting any impulse because it is in the refractory period. So action potential initially travels through the short pathway, and once it reaches the upper part of bundle of His, it finds that the refractoriness of long pathway is gone, right? So now action potential can travel in this direction down and also in this direction upwards and go back to atria. So a backward impulse from ventricle to atria, right? And again it will come back. So this re-entry circuit will keep on happening. Okay. So P wave in ECG is due to atrial depolarization and QRS is due to ventricular depolarization, right? QRS is due to ventricular depolarization. So here what is happening? Action potential is coming from atria through short refractory period pathway, coming to the upper part of the bundle of His, depolarizing the ventricle, but it is also traveling backwards and again coming back to ventricle. So ventricle is repeatedly being depolarized. Okay, ventricle is repeatedly being depolarized. Okay, it is so fast that heart rate becomes 150 to 250. 150 থেকে 250 heart rate হয়ে যায়. Okay. So I told you during exercise class that your heart rate will be maximum 220 minus your age, right? Your heart rate will be 220 minus your age. So this is the maximum heart rate you can raise by exercise in a normal healthy resting individual. But once your heart rate is even more than your HR max, right? If it is more than your HR max, you must suspect there is something arrhythmic event happening in the heart. So this is the thing, AVNRT. Okay, AVNRT, AV nodal reentrant tachycardia. Okay, everyone clear? So heart rate is 150 to 250. So how to identify this reentry from ECG? Any idea how to identify this reentry from ECG? Everyone clear with this concept, how it is happening? Okay, if not, I can tell again.